Welcome to the Transforming Trauma podcast. Transforming Trauma is presented by the Complex Trauma Training Center. I'm your host, Emily Ruth, and I'm so glad you've joined us today. Are you a licensed mental health professional looking to deepen your clinical expertise in healing complex trauma? We are thrilled to announce our Summer 2025 NARM Therapist Training offering, designed to equip you with the transformative power of the neuroaffective relational model. The summer online cohort for the NARM Therapist Training runs from May to December 2025. Through this advanced clinical training, you'll learn how to confidently and compassionately heal the impact of adverse childhood experiences, complex trauma, and CPTSD. You'll gain specialized trauma-informed training that supports the resolution of attachment, developmental, relational, cultural, and intergenerational trauma. Join us and experience the integration of the neurobiologically informed clinical approach that promotes post-traumatic growth. Become part of a community where mindfulness meets clinical expertise and embody professional and personal growth with a catalyst for transformation in your practice and community. Visit ComplexTraumaTrainingCenter.com to register for the Summer 2025 NARM Therapist Training. Enrollment is open to licensed psychotherapists, counselors, social workers, and other licensed mental health professionals, as well as graduate trainees and interns working toward licensure. And now for our interview. William Griffith is a clinical psychologist with over 25 years' experience in practice and extensive research. Having succeeded Dr. Judith Pearson as director of the International Masterson Institute, Griffith now continues to build on her legacy, ensuring the Institute's continued leadership in the treatment of personality disorders. Based in Cape Town, South Africa, Griffith combines his leadership role at the Institute with an active clinical practice, offering expertise in working with patients who exhibit high-risk behaviors. Griffith has also served on the teaching faculty of multiple South African universities, delivering lectures and workshops globally. William Griffith is grateful to be doing this work and is still humbled by humanity on a daily basis. Please enjoy my conversation with William Griffith. All right, I am sitting here with William Griffith. William, welcome to Transforming Trauma. We're so happy to have you.
Thank you. It's a privilege to be here.
Yeah. And I'll just start. Listeners may hear we have a bird joining us in the episode. So if you hear a bird in the back, William, will you tell us what this bird is?
It's a common bird in South Africa. It's called the hardyda. It's a fairly large black bird that makes that strange noise, and that's what's called an hardyda.
Okay. I've been enjoying listening for the last few minutes as we've been just kind of catching up and talking a little bit. And so if listeners hear the bird, we know this is a South African bird. We're happy to have the hardyda joining us today. But more importantly, William, I'd love to hear from you. What would you like our listeners to come away with our conversation today?
I think maybe I'm just privileged to be here to share with your audience the work that we do at the Masterson Institute. It's based on the founder, Dr. James Masterson, that started in the early 50s in New York when he worked in one of the well-known adolescent wards as a young psychiatrist, and he was confronted with the kind of acting out behavior of the adolescents, and he had real trouble understanding the behavior, and that's when he started formulating his theory. His theory is based on, one can say, it's a self-object relations developmental theory that encapsulates all of that. It's fairly governed on the separation individuation concept that was first spoken about by Margaret Mahler. So in essence, it's a treatment approach to the disorders of the self, meaning it's the way the person experiences himself in relation to the object, so to speak. And then he coined the three disorders of the self, meaning the schizoid disorder of the self, the narcissistic disorder of the self, and the borderline disorder of the self. All of these three character structures, as he placed it, presents with a unique split object relation, and then per definition a self-experience presents with different ways in relating or failing in relating with people. But then I think the most important thing is where it's the manner in which Dr. Masterson allowed us to start communicating to this, the pre-uripal condition, meaning where there's no object consistency. You talk to the patient through the lens of Masterson, and then in the so-called, I'm hesitant to call it a diagnosis of the borderline schizoid or narcissistic disorder, there's a certain therapeutic approach or language or intervention that one uses, because the aim is to remove the defenses, to get in contact with the real self and to allow the real self to come to the fore, because in relating from birth, I think we sacrifice a lot of ourselves to become a false self, so to speak. So the essence then of the Masterson approach is to allow the real self to emerge and a person to be whole.
Beautiful. That's so rich. And obviously it's a very complex process that you're working with. And so I'm excited to dig in a little further. So it sounds like a really complex process. Could you share a little bit more about what you boiled the Masterson work down to about the removing the false self? Talk about that a little bit more.
I think it is a complex question and it's probably a complex answer. So I'll try to do my best. Dr. Masterson spoke about what he calls is when a patient enters your treatment room, they are repeating relational patterns that stems throughout their life. So it's a kind of repetitive compulsion. Freud talks about it's a interaction or a relating that is based on a defensive false self, meaning the false self relates to a person, not the real self. So it's a transfer and acting out process, and the aim of therapy is then to remove that defensive part, to put the patient in contact with what Masterson refers to as abandonment depression, which is representative of the real self experience. So the aim of the therapy is to remove the defensive part and allow the person to let go of the false self-defenses and for the real self to emerge and for the person to get in contact with that part of themselves that has been lost during his relating since birth.
Okay, thank you for distilling that down for me. I know our listeners are going to be interested in hearing more about this work. It's very aligned with the NARM work that I do, and so I'm excited to hear more about this. So if we could rewind just a little bit.
Yes.
We mentioned you're in South Africa, but tell us a little bit more about you and where you're located and the work that you're doing in the world.
I'm located in Cape Town. I got involved with the work with Dr. Masterson probably the end of 2005. I think it's an interesting way that I got involved in the Masterson Institute was because at the southern tip of Africa, one is kind of isolated for a very long time. And what actually brought me to this is an interesting concept, is it was pain. Because I spoke to people every day about pain. I spoke to people ending their own lives because of pain. And I realized that people are more than a diagnosis. If a person has a suicidal attempt, it is not about killing the self, it's about stopping the pain. And that's where I started reading and thinking about this. And a colleague of mine is a Canadian psychologist, well published, is Luray Dawes. Him and me joined forces and we flew to Dr. Masterson and asked him whether they would allow us to start an online course. So I think it was 2005 we started a Skype course. And I think what draws me to this work, it allows one a greater understanding of the person. It's a very respectful manner in interacting with your patient. And the premise is that of trusting your patient to act in their own best interest and allowing them to learn more about themselves and to let go and to work with the pain. And that's the abandonment depression, because to sacrifice the real self at the cost of a false self and is a very profound thing in one's life. And for that to start, so yeah, that's in essence, I think, how I come in contact with Dr. Masterson, how it informed my work. So I work primarily with disorders of the self, or one would then I've run things diagnostically with personality disorders. I now work at a psychiatric clinic, so I work in general with a psychiatric population.
Wow, that's really profound. I mean, that you came to this work because of pain. You were working with these humans, these patients, and they were wanting to end the pain. And I appreciate this piece that you said, it's not about ending their lives, it was about ending the pain. And that's a really, like you said, a really respectful way of holding their experience and supporting them through. So how did you get into, because you were already doing this work when you came in contact with Masterson's work. So what brought you to the field to begin with?
I think being a therapist or becoming a clinical psychologist is probably, I think, a road a lot of people travel. And I think I just, by accident, I was, 15 or 16, got one of Freud's publications and I read and I couldn't understand it, probably because English is my second language. And I think then Freud got stuck in my head as a young adolescent, and I always try to figure out, and that's how I got into psychology. People just interest me, and I help them to get interested in themselves.
That's really beautiful. You're just interested in people.
Yeah, it amazes me that people are not interested in themselves, but...
Yeah, that's the complex piece there, or at least when they seem like they're not interested or whatever is going on there.
Yes.
So in terms of, I mean, you're talking about working with patients who clearly have trauma. Was that a part of the human experience you were always interested in, or what kind of brought you, to working with trauma specifically?
I think working with trauma as a South African is a very complex entity, because I think as a South African, one is born into a traumatic society. I mean, South Africa is a very violent society. So I think the trauma experience and the reality in my part of the world might sometimes be different from, I think, what theory talks about trauma. I think it took me a long while I think literature in general has difficulty in really defining trauma, because trauma is such a complex experience, because some person can experience something as traumatic and another might not. But I think what I have kind of realized about trauma in a sense is, it's a difficult concept for me to just formulate on, because as I say, we live in a society. To give an example, in South Africa, I think 1.7 children gets murdered per day. We have 2-point-something women that gets murdered today. We're a population of 40 million. I work with patients that will talk about a rape baby, meaning it's a baby that was the result of a rape. So the traumatic experiences that one sits with, on the one hand, I think that's why it's difficult for me to answer your question. So I'll try to gather myself again and just get on trying to answer you. Because in a sense, I think that trauma, per definition, for me, in working with patients like the borderline disorder of the self or the borderline structure, which because of the developmental history, there's always the need for acceptance, what Masterson will call is the rewarding object relations unit. So there's the seeking of kind of acceptance, avoidance of not feeling good enough, about being rejected. So if you have that, let's say, tendency to please and be drawn to approval, you put yourself at risk. So if one would take a young lady that presents of being a victim of sexual abuse, one would realize that she left the party with a guy she does not know. She put herself at risk. So I think that's always trauma, and the disorder of the self goes hand in hand. And what was first, the egg or the chicken? So I think that's why I'm hesitant to answer something as complex as trauma in such a straightforward manner, because I think there's schools of thoughts that considering that complex post-traumatic stress disorder and borderline personality is the same thing. There's people that's thinking to put the personality disorders on a spectrum.
I'm really appreciating this exploration. I mean, I just recently was having a conversation with a fellow clinician, and she kind of brought up this piece around how she's seen when working with clients who often will come in with a shock trauma and they start kind of pulling back the layers, and there's always there's a complex trauma, a deeper, childhood.
Yes.
And the way she described it is it's like, I feel like they were primed for some of these shock traumas because of their developmental complex trauma that's kind of underneath. And kind of like you're saying, if a woman leaves a party with someone she doesn't know, like what kind of primes her for that sort of experience. And, all of the previous childhood trauma might have kind of shaped her experience in a way that she's open to leaving with someone she doesn't know. And so it's a real, like you're saying, I appreciate that you're holding the complexity and the nuance there, that it's not it's maybe a straightforward sounding question, but it's really complex. And clearly you're holding the complexity of that. So I appreciate that. So in working with these patients, you were drawn to the Masterson work. And so you created a space for this online training. Is that what you said in 2005?
Yes.
Tell me more about that. What did that look like, and what was it you were seeking to do in that work?
I think what draws me to the Masterson approach and the work, because if you read about it, if we look at a person with the borderline disorder of the self-personality structure, the way one approaches the defenses as they present in therapy is through a technique that Dr. Masterson calls it confrontation. But confrontation is a very confrontative word, and it scares people to think about it. But in essence, it allows you to talk in a very empathic manner with the patient and to be actually amazed at what they are doing and the impact of this behavior, and confronting the defenses and to remove the defenses. And I think that is what drew me to this approach, because I think I was fairly at that stage of my career, fairly overwhelmed with feeling not having ability to help the people I was seeing sufficiently. And I think Masterson provided me on two levels. He gave me a sense of belief in myself as a therapist, and he allowed me to make sense of the people that I was working with. And if one looks at the borderline patients through confrontation, they let go of the transference acting out behavior, the attempts to relate. And once that happens, the real self is there, and then one works differently.
Okay. So can you share some of these key elements that are really helping you remove these defenses and helping your patients contact the real self? What are some of these key elements in the Masterson approach?
Yes, I think the key, I think that one needs to look at, if we talk about the Masterson approach, is transference acting out. It's the avoidance of abandonment depression. It is the avoidance of the kind of anti-libidinal, because remember, we talk about the split object relations way of relating. And if we look at the borderline patient, for instance, they would cling to the rewarding object relations unit, because in that unit, they are being rewarded for their clinging behavior, and they feel adored and loved. But as soon as you withdraw that, they move to the other side of the antilibidinal part, where they feel they are rejected, they're not good enough. That typical experiences. So if I can give you an example, maybe just for your listeners to put that into perspective, the way Masterson would look at a patient. If we look at the borderline personality disorder, imagine yourself, you're a 3-year-old 3-year-old boy. Your mom drops you off at kindergarten, and you tell her, you don't need to walk with me. I will walk there myself. I'm a big boy now. In other words, you have activated, you are ready to individuate, you move away and you walk into the class. Your mum, for that matter, is a borderline, a person that feels rejected at that moment. She feels a child doesn't love her anymore. You get back in the car in the afternoon and your mum's crying, and she tells you, you don't love me anymore, you reject me, you don't want me. So what does the boy do? He lets go of that attempts to individuate and he regresses. So there's reward for the regression. That little boy will grow up always feeling that as soon as he activates or does something in his own best interest, he will not be loved, he will be rejected, he will be ridiculed. So in essence, that little boy comes into therapy. He tells you, you've got the softest eyes. I've never been listened to like this. You understand me. That is clinging to the rewarding object relations unit. And then Masterson's approach will allow us to point that out to the patient and to allow the patient to let go of those defenses.
What would that intervention look? I mean, I don't know if that's how you would hold it. Is it an intervention?
No, let me give you an example.
Yeah.
Let's say one would work with a person that comes into therapy with a history of very short-lived, volatile relationships. And you are working with the patient and one is aware, and the patient comes in on a Monday and talks to you about their escapades over the weekend. Then Mastersonian language will allow you to sit back and say, but I wonder how your behavior over the weekend, sleeping with a person using drugs, is going to help you to work at what you came to therapy for in the first place, and that is to sustain a relationship, or just to point out to the patient, because the repetitiveness of the behavior, you will see every person comes into therapy repeating previous failures.
Mm-hmm.
So you will call out a patient on their behavior that is not good for them, but you do it respectfully.
Mm-hmm.
You're not ridiculing a person.
Beautiful. This is like so aligned with the NAR model. And that's often how I've held this piece around the respecting the patient and also the curiosity that I'm hearing.
Yes.
Of you're calling them out, but you're doing it in a respectful way,
yes.
a curious way, wondering like, I mean, I don't know if this is a question you would ask, but, I'm wondering how acting in this manner, maybe in the past it has helped you. I'm curious if you see, is that helping you here? How is that supporting you now and allowing them to kind of work through that inside of themselves instead of, how did you say, instead of pointing the finger or doing it in a way that's not respectful?
Yes, I think the Masterson intervention is never aimed at being disrespectful. It is the essence of being with a patient is based on curiosity. Mm-hmm. You have to be curious about your patients because their parents never were. The growing up, nobody. It's important. We provide a space for somebody where they can feel somebody's interested in me. It's creating a facilitating environment. Winnicottian language would be that's the way you approach people.
Yeah, beautiful. So far, two of the things that have really jumped out at me was this piece that you said about there was a reward for regression. I've never heard it talked about it quite in those words, and that just like really lands for me. Yes. And then this piece about being curious with our patients because their parents never were. And holding it in that way, again, feels really respectful and acknowledging their humanity.
Yes, because if you just look at that curiosity, if you look at the moral defense of Faber, children can never experience their parents as negative. They always turn it, something has to be wrong with me. Mm-hmm. And that's where all of this starts. That's where the false self starts, is where I act in a manner in which my mother will accept me. Tomorrow morning, I will cling to her while she walks me to class because that's what she wants. And I need to be this clinging little boy, which is the false self.
Yeah.
And I will then cling to people in the future. And this oversimplifying of something very, I think, deep-seated.
Mm-hmm. Yeah, I've heard it described as like, I feel like I'm wearing all these different masks, kind of that splitting that you talked about. Like with this person, how I got approval was I wore this mask and I showed up in this way.
Yeah.
And then I had to put away that mask and show up with this person, maybe the other parent and wear this mask. And it could be very conflicting. They may have gotten approval from their parents in very different ways and how confusing those different masks and all the splitting. So again, I'm just really appreciating how you're describing this and distilling it down in a way that feels really helpful.
I think if you talk about different masks, Candace Orcutt, it's one of the Mastersonians. She lives in New Jersey. I think she published a book last year, The Unanswered Self. And in that book, she, at the end, I think the last chapter in the book is on trauma, and she speaks about the states. I think the ego states, she's relating a lot of that work into, so the masks is a metaphor for, I think that we hear a lot. And just for interest's sake, if a patient can talk to you like that about the mask, one would assume that they have progressed in therapy, because then there's no more transference acting out. Then there's the self-reflective capacity. And that's what one aims for in therapy, is for people to start to really thinking about themselves.
Yeah. Yeah, I appreciate you naming that, because being able to self-reflect and almost observe their experience and talk about it in that way can feel so organizing for themselves.
Yes.
And
Yes.
anyway, yeah. So share more. There's so much I'm curious about. I know that there's so many different things you could talk about, but what feels important for our listeners to know in terms of understanding the Masterson work?
One thing I can point out that stands out, it's a process of allowing somebody to relate. It's as if you allow somebody to come out and play for the first time, to let go of the defenses. It's a painful thing to see a person maturing through their childhood pain. But I think for me, it's just stopping the repetition, allowing somebody to self-activate and start acting in their own best interest. I think there's nothing greater than that, for the real self to come out and play, to be the witness to that. It's also sad, but in essence.
Yeah, and I appreciate you naming that part of the complexity that a lot of patients, clients, as they're starting to connect with that real self, there is like grief that comes up because of, they start, the way I've heard it described is like, there's so many years that I couldn't be myself. And it's like, now I'm finally doing it at age 30, 40, 50, and feeling into the grief of that.
Yeah. But I think if I can just maybe hijack your statement, it's very important what you are, but if one just moves back a bit, if you think about what happens in therapy when one is in that process, let's take simplistically the depressive position of Melanie Klein, is where the infant becomes aware of having an impact on the object, of damaging the object, having the ability, the guilt, the shame, and all of that. I think that comes in therapy, especially if you work with the disorder of the self. Because remember, as soon as they become aware they can lose you. And then there's the defense of it's a self-activation leads to abandonment, depression leads to defense. And as soon as that awareness, which is very infantile, that I am separate from you, and for me to be able to relate in a whole object relations manner, that is sometimes overwhelming for the patient. That if that happens in therapy, one goes through a phase where again, there's a lot of regression taking place and accusations of you abandoning, you leaving. Can I trust you? What are you doing? That.
Yeah, there's so much there. Maybe you can share a little bit more, and maybe you have other stories you can share in terms of like what this unfolding looks like as they kind of peel back these layers. And how did you say it? As they're removing their defenses and they're getting in contact with their real self. Can you share any other examples?
Yeah, let me reflect. Last night I spoke to somebody about the narcissistic disorder of the self, and they reflected on one of the cases that Dr. Masterson wrote up in one of his books, which was, if one looks at the working through phase, where the patient mentioned and came into insight, where the patient said to him, I come to you every day expecting you to give me an answer, to give me hope. And then you make me feel as if I am supposed to do it. And then the patient went on to realize that you cannot give it to me. I need to find it in myself, but then there's an emptiness. And once they start talking about that emptiness, it's a bodily experience, it's a physical feeling, but there's a realization that something has to be inside me that's not there. It has been taken away, and then one starts with the exploration of the real self, and then the real self will voice. Then the real self will say, my father never approved. You will hear words like, I was never good enough. Why was I never good enough? Why was I never approved of? Why? Or memories even coming back. Why did my sister have an aircon and I not? these things will come back.
Mm-hmm. Yeah, it's taking a second for that to like settle for me. Maybe there's part of me that feels like, oh, this is so complex and I'm trying to grab it. I'm trying to like hold on to it. So yeah, maybe it's my anxiety getting in the way.
It is overwhelming, but it's not complex. It is learning somebody to relate. And it's also, I think, and this is the most important thing, is for the therapist neutrality. For the therapist to sit there and being able to hold the frame, hold the patient. And the theory informs that. And it's learning somebody to relate and being strong enough to survive the attacks and to allow the patient to form a consistent object relation. It's as simple as probably just sitting there and not being bullied, not being overrun, not allowing the person to do something bad for them, just being there.
I appreciate you bringing it back to the simplicity. And I guess simplicity doesn't always mean easy. As a therapist, what you're saying, or what I think I'm hearing you say, is like the simplicity of just allowing space for someone to relate and these things to kind of unwind. And like, what does that mean as a therapist? And often I'll just name from my own experience, like if I'm having some countertransference coming up and I'm trying to like ground into, okay, what's really important in this moment instead of feeling into the noise that might come up for me. But creating that space, like that is simple. It doesn't mean it's easy, but it is really simple. And I appreciate you naming that, because I'm thinking, oh, well, the noise that comes up for me, or that feels all complex, but that's not actually what we're talking about. We're talking about kind of stripping away all of that and landing in the simplicity of it. That's how it landed for me, at least.
I think if I can just latch on with that, if you would just bear with me, I think that's also the core part of Masterson's writings, is we cannot react to the patient's transference acting out. Remember, it's called transference acting out because it's not real transference. It is acting out. It is based on the false self-assumptions. It's acting in a manner in which you expect what the object wants. It would be too simplistic if a person comes into therapy accusing you of being just in this for the money. They are devaluing you. Or a patient is flirtatious with you. That's not transference. That's transference acting out. It's the way they relate. And that is the defenses that gets removed. So as soon as those things are out of the picture, then one can have a transferential relationship that can work. Then it's you and me. It's not my defenses. It's not my false self.
Yeah, I really appreciate. I've never heard it talked about quite in that way. So transference acting out, you're saying that's like when their false self is coming up and they're acting out of that, not out of their true self.
Yes.
And so what you would say is when they're acting from their true self, would you say that's transfer? Am I getting that wrong?
Then you have a transference. Then the person can actually relate.
Oh, interesting.
The disorder of the self is a pre-ripple condition. So there's no whole object relations. The object not been integrated yet. It's a split. So for your patient, you can only be a good therapist or bad therapist. It depends on how they relate to you. For the mature or the patient that is working through issues, you are an object that can be good and bad. I mean, if we read Winnicott's work, a mother's bound to fail her child. That's how we get brought up, by a good enough mother. She fails us. She's not there every minute we're hungry. If we fall down and get hurt, she's not always there to stop that. And that's what I think we as therapists need to become comfortable with. You can't anticipate everything about a patient. The narcissistic disorder of the self might be very attuned at empathic failures, but we are bound to fail them empathically. But if the relationship is strong enough and they pick up on that, we can repair and carry on with therapy. And that can only take place if we can relate to each other on a consistent whole object relations manner. The rest is pure acting out and defensive behavior that needs to stop.
Okay. this is familiar territory. These are things I've talked about, I've learned about. And the way you're explaining it, it's like it's a landing from a different angle. Like it's just sort of, I don't know, I'm really appreciating just the languaging of how you're talking about this, because I feel like it's landing a little bit deeper for me. And I imagine our listeners will have their own experience, but I'm really appreciating it. Yeah. Yeah. I'm just really, again, curious, because there is so much here that it's a very rich model that you're working with. Is there anything else that feels, like territory you're wanting to share?
In essence, I think Masterson gave me a new respect for therapy as a treatment method, and I've seen the benefits. I've seen people improving, and I've seen people re-entering life. I think as therapists, we are so dead set on a cure, and I think we don't even know what a cure looks like. I think if we can just allow people to experience themselves. And I think what I got from Masterson, and what I hope every therapy can do, is to allow people not just to relate to others, but to relate to themselves. Because the greatest mistake we make is to think everybody has got a relational issue. Yes, it is a relational issue. Everybody we see have difficulty in relating to people. But it's because they don't relate to themselves. They seek in others what they can't find in themselves. And that is what I think Masterson has provided me, is a way into that space and to work with people on a level where they start caring and being curious about themselves.
Yeah, I so appreciate that. And I'm thinking of experiences, holding this space of clients who have kind of described, a way of externally trying to maybe find stability or find connection. And not that connection outside of ourselves is wrong, but really seeking only for that. And like what you're saying, not finding it within themselves, and then seeing that kind of shift back to themselves of, I can find stability here. I can find connection here. And then connection with others growing out of that. But first, that we have to be connected to ourselves. And it's really beautiful to watch that process unfold. And I just appreciate you naming that.
Yeah, like you probably picked up by now that English is my second language. I think maybe that's why I don't have all of the big analytic words readily in my vocabulary to impress people with. But I think therapy is more than big words. It's sometimes something that big words cannot describe, and intellectual sentences. And it's words people, remember, we think, we feel long before we can speak. You feel hungry as a baby. You don't say, I'm hungry. So we get so caught up in words and in describing things that we forget we're working with feelings, and we're allowing our patients to find words for what they are feeling. We can't tell them what they feel. We have to just sit there and allow them to come with those words themselves.
Again, I just really am enjoying even how you're talking about it, the languaging. I appreciate the bringing it back to the simplicity, because you're right. The big words don't matter. That's whatever. But the bringing it back to what is it really about, and the simplicity there is really, really useful for me. So yeah, I think it's great that you're the way you're able to talk about it.
And I'm probably deliberately avoiding talking about my patients because, in essence, I don't publish, I don't talk, I don't write, because what happens in this room is the person sitting opposite me, it's their space. I've got no right to intervene or to recall their story. It's their story to tell. So that's why I don't use examples.
Yeah. And what I'm getting from it is that you're talking about the process without, like you're saying, without talking about their story, but that you're able to share what the process is like. And that's really the most important piece. So yeah, thank you for that.
Yeah. A patient once summarized treatment after 6 years saying that nothing has changed, yet everything has changed. And that is, I think, what therapy is. Nothing changes, yet everything changes.
Yeah, that's a beautiful. a beautiful segue as we kind of come to closing.
Mhm.
William, thank you so much for taking the time, and we're in like completely opposite time zones. So we're well into the evening for you, and just really thankful that you've taken this time and given this space to share with our community. And I'm wondering if there's any kind of last pieces that you'd like to share, and then also how listeners can find you and contact the work that you're doing.
Yeah, thank you for the opportunity as well. The Masterson Institute runs a 3-year training program that starts every year in January. This year, we're taking a break to reshuffle the content a bit. The Masterson Institute in South Africa, they are starting a 6 months treatment of the schizoid disorder soon. So people can look up the International Masterson Institute. There are training programs. There are people that do, I think, provide supervision. I know there are people that do online therapy work. So if everybody's interested in working with a therapist, I'm quite sure they will find somebody there. I don't work online. People are welcome, that people can write in. I'm quite sure we can answer questions that they want answered, especially clinicians. We're more than willing to engage with other clinicians as well.
Beautiful. Well, thank you again for sharing your time with us and for giving us those resources. I'm sure that many people will be interested, and hope you have a lovely evening.
Same to you that side. Bye, Emily. It was good meeting you.
It's good meeting you too.
Cheers.
Thanks so much for joining us for today's episode. To find more information about our guest, check the show notes or visit us at complextraumatrainingcenter.com/transforming trauma. You can also connect with us in other ways. We're on Instagram, Facebook, and YouTube. As a mental health professional, your commitment to healing and growth inspires us. We at the Complex Trauma Training Center are committed to supporting you in your well-being and success. That's why we're honored to invite you to our Space Program 2025, an inner development program of support and self-discovery for therapists on the personal, interpersonal, and transpersonal levels. Running over 6 online sessions in 2025, this interactive experiential learning program is designed to support self-care and self-discovery for therapists, exploring internally, relationally, and transpersonally. CTTC faculty will welcome you into a professional community of therapists that are seeking to create greater effectiveness and resilience in our professional lives. As CTTC faculty Brad Kammer says, the intent is that this program will help us not only become more effective therapists, but also love our work more. Please visit complextraumatrainingcenter.com and secure your spot in the 2025 Space Program. Thanks to Andrea Klunder and the Creative Imposter Studios for producing and editing, to Elisa Sponseller for our album art, and to Brad Kammer for the creation of this podcast. We look forward to building community and connection with you and changing the world by transforming trauma.